Hello everyone, so this is Seher and we are going to do the review of oral surgery today. So firstly we can see the table of contents, which is indications, contraindications of dental extraction, learning about the impacted teeth, principle of surgery, suturing, trauma surgery, classification of fractures, how to manage them, mandibular fracture, midface, maxillary fractures, surgeries, facial pain, biopsies, different types of nerve blocks, non-surgical therapy for temporomandibular and surgical therapy for temporomandibular diseases, TMJ reconstruction surgeries, bone healing, odontogenic infection, complication of sedation, and management of medical emergencies in the dental office. So we firstly start with the indications and contraindications of dental extractions. So indications we can see severe caries when you have pulpal necrosis, severe perio disease, for orthodontic purposes, malpose teeth, pre-prosthetic extraction, impacted teeth, supernumerary teeth, where we are doing the dental extraction. However, in the cases of severe uncontrolled diseases like diabetes, end-stage renal disease, these are all the contraindications on the right side. Advanced cardiac conduction, if the patient has let's say 6 months after your bypass surgeries to have elective extraction, you have to wait. Leukemia, lymphoma, radiation therapies, because we don't want the osteoid necrosis to happen. Pericoronitis cases, acute infectious condition, if the patient is taking the bisphosphonate therapy, chemos, steroids, pregnancy in the first and third trimester of the patient has severe bleeding disorders. Okay, so now here we see the complications of extraction, that is anywhere from tearing of the flap, puncture wounds, formation of a oroentral fistula, root fracture, tooth getting displaced, injury to the adjacent teeth, fracturing the maxillary tuberosity, and trauma to the nerve. Also, the important complications of extraction could be excessive bleeding, especially if the patient is a hemophiliac patient. Dry socket, very, very important, localized alveolar osteitis, or having air emphysema. If you're using non-surgical handpieces, which are also throwing air into your tissue, it can lead to cervical emphysema. Now, dry socket is a very, very important condition, also called as alveolar osteitis. So this is usually caused because of increased fibrolytic activity or a breakdown or loss of the clot. So patient has not followed your post-operative instruction. He has smoked, spit hard, rinse with hot liquids. The clot is going to get dislodged. Dry socket is mostly seen in mandibular molar extractions, and the patient will have very worsening throbbing pain, radiating pain, and bad odor and taste. Very poor healing at the extraction site. So treatment here is not to give any antibiotics, but just do the eugenol dressing to the patient every 2 days until patient becomes asymptomatic. Now the extraction tips, as we know, we are removing maxillary teeth before mandibular, we are removing anterior teeth before the posterior, and the force of extraction with your forceps should be apical. Now we can see the dead space. So after you have extracted the tooth, like an impacted tooth, you go deep into the bone. So you are removing the tissues in several layers. Now, while you are suturing it back, you have to suture it in the same way. You have to reapproximate the wound in different layers. If you don't do it, it will create a dead space below, which is filled with blood and bacteria and creates an infection there. So apply pressure dressing, closing wound in layers using drains will help you in eliminating the dead space. The different ways of achieving the hemostasis, pressure, suture, electrocautery, thrombin, and the other ways you can see here, but pressure is the most primitive or the initial method to achieve hemostasis. Now this is the dangerous area of the face, you can see here, where the apex is at the infraorbital region and the base is at the upper lip area. And why it is called as a danger triangle? Because veins in this part of the face, they don't have the walls. So blood flow or venous drainage from this part of the face can go back into the sinus, and from the sinus can flow to the brain, because sinus has all the connections with the cranial nerves. So that's why it is called as the danger triangle of the face. Now the primary intention Secondary intention healing. Primary intention healing happens when you have a nicely suture approximated surgically incised wounds where healing happens without scarring. While secondary intention is like a closed wound that is healing, so there's lots of granulation tissue, collagen, and there's going to be scarring. For example, in gingivectomy, we have the secondary intention healing. Now we can see on this slide the different types of fractures. To start with, simple fracture, compound, which are complex fracture, comminuted fracture into multiple pieces. Then you have the green stick fractures in children. They have more green stick fracture because one side of bone is only broken, other side can be just bent because their bones are more elastic. Then we have the pathologic fractures like in osteoporosis, we can have pathological fracture. Now, the mandibular fracture, as we know, it's a very important topic. It can be seen on panoramic radiograph, but at least you should take 2 radiographs to visualize the mandibular fracture like pans, Townes, PA skull, lateral oblique, and malocclusion is the most common pathognomic sign of the mandibular fracture. So we can have fracture most commonly on the condyle, and second most common site is angle, and the least common site is cornoid process. So fracture of condyle is going to result in deviation on the opening of the fractured site from the trauma to the same site lateral pterygoid muscle. So bilateral mandibular fractures may result in posterior displacement of tongue that will cause airway obstruction. And the fractures that are displaced that have to be treated with open reduction. So there are 2 types of reduction. Open reduction, when you're surgically opening up the fractured site and doing the reduction under direct vision by using plates, screws, wires, and the closed reduction, like in case of condylar fracture, you can do a closed reduction. When you are not surgically opening the fracture site, you are just manipulating through the maxillary and the mandibular bone. So what you are doing the intermaxillary fixation, and you're closing both the maxillary and mandibular teeth in occlusion. So slowly it will heal the condyle. While in case of angle of mandible, which are usually displaced fractures, you are going to do open reduction. So why angle of mandible is a displaced fracture and why it is the unfavorable fracture? Because of the pterygomesenteric sling, the medial pterygoid muscle and the masseter attached at the angle of mandible, it is going to displace the mandible segments apart from each other. So you can see here what is the different treatment modalities that are also given here. So trigeminal neuralgia or tic doulorex, as we know, it's a very important condition. We can see more details of it and how we treat the 3 types of trigeminal neuralgia like idiopathic, classical and secondary through this flow chart. So trigeminal neuralgia, as we know, it's a trigger point exists when pain typically present as electrical sharp shooting pain that is triggered by wind tactilothermal stimulation. The pain is going to be very episodic, that lasts for seconds to minutes and followed by a refractory period. It's usually a unilateral pain we have. We can use anticonvulsant like carbamazepine, that's the first line of drug, surgically by using the Geneta procedure or gamma knife radiosurgery, or using the conservative treatment where physiotherapy, moist heat, motion exercises, the night guard, massage and NSAIDs are going to help. Further details of trigeminal neuralgia treatment is given in this flowchart that you can go through it. Now this is post-herpetic neuralgia. So after suffering from zoster or the shingles attack, patient can suddenly develop the neuralgias, burning, aching or electric shock like pain. That combined with facial paralysis, vertigo, deafness and cutaneous eruption of external auditory canal is called as Ramsay-Hunt syndrome. Okay, so on this slide, we can see different types of biopsies. Always you give the block anesthesia, not the infiltration, because you don't want to distort the anatomy of the lesion. Low volume suction is being used because you don't want the tissue to get aspirated inside. And incision using a sharp scalpel to avoid any excessive damage. You can also use laser if the hemostasis is of concern. Then you are going to put the biopsy tissue in a 10% formalin with a volume 20 times that of the specimen. Now, oral brush cytology, which you are usually using for fungal condition or detecting cancerous and precancers, in which you are using a special type of cytology brush that is placed over the lesion, rotated 5 to 10 times to obtain the cell from all 3 epithelial layers. And then the cell is transferred to the glass slide and the fixative placed and sent to the lab. So if it is negative, there is no evidence of atypical cellular carcinoma. If it is positive, there is definite evidence. It is atypical, that means it's abnormal epithelium. So both positive and atypical results, they should go for a definitive scalpel biopsy. Now, fine needle aspiration cytology, in which you are using a special syringe and you're collecting the cells from the sample. And using this technique, fine needle aspiration cytology, it is used to determine, very important is to aspirate just to be sure you're not inside the blood vessel. Incisional excisional biopsy we already discussed in oral pathology. And also when you're doing biopsy a lesion, you always wait for 2 weeks of time. 2 weeks of time, if the lesion is not regressing, then you can go for the biopsy of it. Except in the case of erythroplakia, where you are going to send the patient to oral pathologist the same day you are seeing the patient. Okay, so before we start by different types of nerve blocks topic, I would like to add more points on local anesthesia. So if they want you to calculate the maximum dose, maximum number of carpules that you can give to a patient of certain weight, simply you have to firstly take out the maximum dose for the patient of that weight divided by 36. That will come to the maximum number of carpule. Now, if they have given you the weight in pounds, you have to divide it by 2.2 to convert into kgs. For example, a 44 pounds child divided by 2.2 will be a 20 kg child. They can also give you question not only lidocaine, they can give you question on 3% mepivacaine or 4% prilocaine. So if 1 ml of 2% lido has 20 milligram of lido in it, 1 ml of 3% mepi will have 30 milligram of mepi in it, and 1.8 ml will have 54 milligram of mepi. So that's how you can do the calculation for the mepivacaine, prilocaine, which is 4%. The calculation will be likewise. Now, there is one concept called as differential nerve blockade concept, in which the nerve blockade is the maximum distance action potential can jump down the nerve. So in myelinated nerve, the local anesthesia must block a minimum successive number of node of Ranvier to block the action potential. And the sensations which are first to go is pain, and last to come is pain. So pain, which is conducted by small myelinated, unmyelinated fibers, will go first, because local anesthesia will be more sensitive to them. Then temperature, touch, pressure, motor are the very last sensation to be gone by local anesthesia. Now we should know that why local anesthesia, it works not good in the acidic environment. So once local anesthesia enter into your tissues, it get converted to the ionized and the non-ionized form. So the non-ionized form is a free base form that is lipid soluble. The ionized form is not lipid soluble. So ionized form we need to block the sodium gated channel, but the non-ionized form is the one that is needed to penetrate the nerve cell membrane and to produce the anesthesia. Now what happens in acidic condition, all the ionized form becomes more, it is more available than the non-ionized form. And the ionized form, we know it's not penetrating the nerve cell membrane, so anesthesia is not proper. But when the conditions are normal, when you have a tissue pH of 7.4, 7.8, we have enough amount of free base form or the non-ionized form that is available that will penetrate the nerve cell membrane and produce the anesthesia. Now we see the topic of different types of nerve blocks, that we can see the greater palatine nerve block, the PSA, the posterior superior alveolar nerve block. So for the maxillary, we have the PSA. Area of anesthesia is from maxillary third molar into maxillary first molar, but the mesiobuccal root of maxillary first molar is innervated by MSA. Then ASA is the infraorbital nerve block that is blocking both ASA and MSA. That is from midline of maxilla to the mesiobuccal of maxillary first molar. Then we have the greater palatine nerve block that is anesthetizing from canine to posterior aspect of heart palate, as well as gingival margin to midline of heart palate. We are giving this anesthesia greater palatine foramen halfway between gingival margin and midline palate, 5 mm anterior to junction of hard and soft palate. Then we have the nasopalatine nerve block. Area of anesthesia is from palatal tissue from canine to canine. The mental nerve block is given, is anesthetizing the soft tissue on the buccal from premolar to the midline lip, chin, periosteum, and the bone. So that is, these are different types of maxillary nerve block that you can see in the picture. The most important, we should know the landmarks. So where they are exactly given. It is further given in my notes, and we can also see from the picture. Now we can see surgically how we are going to manage the cyst, like enucleation, marsupilization, enucleation, curettage. Enucleation, you can see you're completely shelling out the lesion out. Enucleation, like in small cysts like mucocele, you can do that. But surgical management of bigger cyst or ranula, for example, in the floor of the mouth, it's a big lesion, you cannot completely take it out. You cannot do enucleation, otherwise you can damage the blood vessels and nerve. You can do marsupilization, in which you make a surgical window in the cyst, decompress it, evacuate the content, and then make the cystic lining continuous with epithelial lining. That's called as Pash operation. The problem with marsupilization is that some infected tissue can still be remain. Sometimes you are doing the stage enucleation and marsupilization. So once you've done marsupilization, after initial healing has happened, you can do the enucleation. Sometimes enucleation you have to follow with the curettage, because let's say OKC, that are very aggressive cyst, you reduce the chances of them recurrence. So you have to do enucleation and then you do the curettage of the surrounding 1 to 2 mm of tissue. So chances of recurrence becomes less. Hi, my dear student who are preparing for IMD ADAT Part 2 exam. Thanks so much for watching this review video of the subject. If you really liked it, please buy the full version by clicking on the link given in the description. With the purchase of every video, you will be getting free live assessment and evaluations on the subject as well. Also, don't forget to subscribe to the Dentabest channel now to get the latest updates on the smart videos. If you have any questions, please comment me in the box below. I, Dr. Seher from Dentabest, wishes you all the best for exam, and thanks again for watching.